experience with spinal cord injured patients and taking care of them. And I wanted to thank her for coming to do this lecture. It's always an awesome presentation.
Thanks, Jay. Hi, everybody. This is my first experience at giving a presentation over Zoom, so bear with me a little bit. Hold on just a second here. All right, and let's see if I can get this to work. All right, can you guys see my screen that says PHTLS?
Yes, ma'am.
Yes, ma'am.
All righty. Hold on just a second. Still just see the slides, and then you can probably just see me speaking if you have me on speaker view as well.
Yes.
Okay, cool. Thanks. So I am actually, I'm using two screens, and I've got speaker notes and the slides in front of me as well. So Dr. Rossi has spent a lot of time talking about traumatic brain injury, and I'm going to follow here with spinal cord injury and vertebral column trauma. And when you think about the brain and the spinal cord, you really have to think about it as one continuous, piece of neuronal tissue. It's the exact same. The brain has the gray and the white matter, like Dr. Rossi talked about. The spinal cord has the gray and the white matter as well. And then there's nerve roots that come out of the spinal cord at all the different levels. The other thing that I think it's really important for all of you to think about as you take care of patients, both in the field and other places that you work, is that there are thousands and thousands and thousands of patients every year who have vertebral column injury, fractures to their vertebral column, and have no associated spinal cord injury. And a much, much smaller percentage of patients actually end up with neurologic deficits, and even a smaller percentage of patients have very profound or very severe and permanent neurologic deficits. Now, that's not to say for you all, as you respond to the scene and you think about what you're going to do for that patient, when you get to the scene of a call, is not important because, oh, it's just vertebral column. It's critically important that you are really observant. You really kind of put the pieces of that scene together. You listen to the call. You listen to the information that's been called into you or is provided to you by bystanders, etc., as you begin to assess your patient and take into consideration the management during transport. So these are your objectives. I'm not going to read them. There is a lot of information about spinal cord injury as well. And then we'll talk a little bit about the spinal motion restriction. And there's information here about who should be immobilized or who should have spinal motion restriction. And again, I'm going to defer. This is what PHTLS says, and each of you work in different agencies where you have different spinal motion restriction protocols and who's going to have full immobilization versus maybe a C-collar and not a backboard. And so I defer to your expertise in what your operational medical directors have determined and how you work with them for the best care of your patient. And the last thing I would always say is always err on the side of caution. So if there's anything in your head that says, I'm not so sure, to me, that's the time where you would choose to be more restrictive or more immobilization than less immobilization in the interest of good patient care as we go through this. So here's your case presentation. It's a typical day. It's 82 outside, I think. We got lots of people getting outside. They're in the water down at the river. They're in their swimming pools that have, if they have personal pools, et cetera, and some of the public pools are opening up. And not untypical of something like today, you've got a 24-year-old guy who you hear has been outside playing in their pool. He dove headfirst into their pool, and he was removed from the pool by the bystanders. And the dispatch says that the patient is unable to move his arms or his legs. So let's think about this. As you're responding to the scene, what are the things that you're thinking about?
A loss of consciousness.
Okay, does he have a loss of consciousness? And maybe he has a concomitant traumatic brain injury as well, which will potentiate the need for more care and management, as Dr. Rossi talked about. Anything else?
Was it a water rescue? Like, did he go unconscious but never came up and people had to take him out of the water?
Okay, outstanding. That's a very important, because if he was underwater for a long time, even if he, you know, had a couple breaths or whatever his respiratory rate, he may absolutely be, you know, he may have inhaled water and have an associated pulmonary injury, which you're going to have to manage during transport. Anything else?
I know sometimes it's more common to have a saltwater pool, or like you have a saltwater pool and then a regular chlorine, so the type of water may also affect things.
Yeah, so that's really important as well. So what was the type of water, if you can find that information? Is it salt water? Is it tap water? Or is it natural? You know, is it a lake or a pond? Now, that may not be necessarily what you're going to have to deal with in the 15, 20, or 30-minute transport for that patient, depending on your situation or where you work. But it's definitely important for us as part of the teams that are receiving these patients, because that's going to affect what that patient's pulmonary status may or may not do as far as deterioration, because there's different physiology between that, and also the risk for very, very profound infection, pneumonia, if you're out in a pond or a lake because of the bacteria in those waters. Anything else?
When they removed him from the water, was anybody like trained for that kind of movement of the body without injuring more spine?
Okay, that's a really important question too. Was anybody actually providing any sort of C-spine precautions or protection, or did they just yank him out of the water? Because that actually could have potentiated the injury. I would definitely agree with that. Any other thoughts? The other thing to think about, and this was actually an experience that I had a number of years ago when I worked at another trauma center in another state, but it was in the middle of the summer. It was hot and humid as it is right now. It was very hot and humid. And there was a patient that was ejected from a car crash. Now this isn't, you know, this guy dove into a pool, and he laid outside overnight, okay, before he was found by EMS or family or whoever found him. And when EMS arrived and he was brought to the hospital, his core body temperature was down in the 80s. All right, that's not compatible with survival. All right, and the guy did ultimately die of multi-system organ failure. So even though it's 82 outside, it's warm, it's hot, it's humid, you guys are sweating, I'm sweating when I'm outside. 82 is very hypothermic, and so if a person is in the water, I actually have a swimming pool. My water temperature in my swimming pool is set to 83. So these patients can actually, if they've been exposed for a while, can quickly become hypothermic. And so you have to also think about the associated complications or risks with a patient developing a core body temperature down in the lower 90s or even lower. The dysrhythmias, if they have any open wounds, the risk for the development of coagulopathy, because now your platelets don't work and your other clotting factors start to lose. That clotting process starts to become dysfunctional when a person becomes cold. So this is great. You guys have come up with some really good thoughts on what to consider as you come upon the scene, and aspects to consider related to this patient, related to the scene. A shallow pool, the risk of traumatic brain injury, the risk of inhalation, or not inhalation, aspiration, the type of water that the person has dove into or has been in, the risk for additional injury because of how he was pulled out, and then I added the concern or the risk of being hypothermic. So obviously this guy, it says that he's got this abrasion or sort of hematoma that's developing on his forehead as he jumped or dove into the pool. And he is actually saying he can't move. He's actually warm. His pulse is a little bit weak, but he definitely has a pulse, and he's got some manual ventilations. So the last question on the screen says, should manual spinal stabilization be performed? And that's sort of a no-brainer. I think for you all, the question would be, is it full C-spine immobilization, or is it more a limited C-spine immobilization?
I'd go full since you.
Absolutely. Absolutely. You don't have enough information, and simply by the fact that he doesn't move tells us maybe it's temporary, maybe he's scared to death. We've had a few people like that, but you can't assume that it's just something else. So the scene appears safe. You find out that the patient dove into this pool. He didn't surface, as somebody said. He was pulled out. He was placed on the deck. He's lying supine, and he's actually, again, able to talk to you. And he says that he's complaining of neck pain. So the other concern, and somebody raised the point that it's important that you think about, associated traumatic brain injury. Is he unconscious? But is the patient, has the patient been drinking, or have they been doing any sort of drugs, that their mental status is compromised because of that, and they can't actually give you a good history. They just don't have a reliable history. So this guy says he's complaining of neck pain, but other times you're going to have situations where you have patients that have distracting injuries. Maybe they've got a huge femur fracture from a motor vehicle crash or other injuries that they're complaining of pain from, and they don't actually, associate pain in their neck because their other injuries are more significant. So that's another reason where using your brain, using your eyes, your ears. I always say to people, you can save a patient's life with your eyes, your ears, your nose, your mouth, your hands, and I'll give you a stethoscope. You don't need anything else. So use your brain and use that assessment that you can do as far as the scene, the information that you get from the patient, from the bystanders when they're available to make that really good decision. So this guy's complaining of neck pain. That's another indication for you all to say, this patient needs full spine immobilization. He's got no significant bleeding. Again, his airway is open and patent, but as somebody mentioned, you certainly have to have a concern that this patient could have compromise to his airway. If there was any loss of consciousness, he has the risk for developing respiratory distress if he has any sort of pulmonary injury from aspiration. And certainly it says he's got a fast but normal chest rise. Now, some patients who develop cervical spine or spinal cord injuries, I should say, not cervical spine, develop what is called diaphragmatic breathing. And those of you who have children or have taken care of pediatric patients who are in respiratory distress, you kind of see their abdomen pooch in and out. And really, a child uses their abdominal muscles more than their chest muscles initially. So they are diaphragmatic, they're abdominal breathers by nature because their chest wall isn't as strong, those intercostal muscles. If you see a patient who has they're pooching in and out their belly as they're trying to breathe, or they're grunting. Sometimes we think grunting is a airway problem. That's stridor. Grunting is really a breathing concern. So that would be, again, a red flag that they're just not able to generate a breath well enough and with ease. The guy's got a slow, thready pulse, but his skin is warm and dry. His GCS is 10. I'm not real happy with that GCS. Again, he's able to talk to us a little bit, but again, he's not able to move. You've got to just make sure that he doesn't have any further deterioration in that verbal score. And then when we think about vertebral column and spinal cord injuries, again, you've got your vertebral column, the bony elements, you've got ligaments, and you've got muscles that are attached to the bones that support the bones in alignment, and they keep them strong and in line so that they're not moving too much. And a patient can have a bony injury, the patient can have soft tissue injury, the ligaments can be torn or stretched, the muscles can be stretched or torn. We've all had muscular strains in our back from moving patients and lifting, etc. And then you can actually have, damage to the cord. And the leading cause still remains motor vehicle collisions or moving vehicle collisions. We see it associated with motorcycles. We also see it sometimes with ATVs and sports type vehicles, especially in more rural areas. We see a lot of patients, and now with our elderly population and the rapid increase in elderly trauma, geriatric trauma, we're seeing a lot more patients who have vertebral column and spinal cord injuries associated with falls and even lower energy falls. Other things that we see, obviously, especially in the Richmond area, unfortunately, at times is the penetrating injuries, and then obviously sports. So again, vertebral column the bones can be fractured, the ligaments and the muscles can be stretched or torn, your sprains and strains, you can actually have damage to the cord itself. Or you could have damage to all three. A patient could have damage to all three supporting structures. And that's our job once the patient gets to the hospital, and our orthopedic and neurosurgical spine specialists to determine what the real injury or degree of injury is, and what the associated management, surgical or stabilization management. Just like Dr. Rossi talked about, you've got with your neuronal tissue of the spinal cord, you've got your primary injury, you've got your secondary injury. The injury that occurs to that patient in the car crash, the fall, the gunshot wound or the stab wound, whatever it is, you and I can't do a whole lot about that except with our emphasis on injury prevention, risky behavior modification. But you and I as providers in the field, in the emergency department, across the continuum of care, we can make a huge impact in the overall outcome of patients with respect to the secondary injury. Just like in the neuronal tissue of the brain, that penumbra that Dr. Rossi talked about, the spinal cord can have these little areas where the tissue is dead, and there's areas around the tissue that is the dead tissue that can recover, and then there's areas that are just sort of minimally injured. And we have to really make sure that we do the best care for our patients through immobilization, good perfusion management, etc., so that we can kind of keep that damage as minimized as possible. So what are some of the secondary causes? Any cells in the body, your arm, your leg, your spinal cord, your brain, if it gets bruised or shaken up or jostled, you're gonna have edema as there's injury or damage to the tissues. And that edema causes compression of the nerves within the spinal cord and renders the nerves damaged. It causes ischemia, and that's what causes that nerve tissue to actually die, and the patient has neurologic deficits. Patients can have bleeding around the cord, just like Dr. Rossi talked about epidural and subdural hematomas. A patient can have bleeding into the spinal cord between the meninges of the cord, and that hematoma will form within the spinal cord and compress the tissue. Just like it compresses the brain, it compresses the tissue. Again, essentially blocking perfusion and oxygen delivery to the spinal cord, particularly at that level and below the area, and then the patient develops neurologic deficits because there's ischemia to the neuronal tissue. Excuse me. Patients who have increased intracranial pressure they can also have pressure within the cord. So especially in this time of the year when you have a patient, with a spinal cord injury or potential spinal cord injury and a traumatic brain injury, keeping the intracranial pressure low is not just important for the brain, but it's also important for the spinal cord itself. And then seizures are another reason that there's a risk for further neurologic deficits, because now we're using up all of the amino acids that are in the neuronal tissue because of the seizure activity. And so early seizure prophylaxis with anticonvulsants is important once that patient gets to the hospital, or if you're transporting that patient as part of an interfacility transfer as well. So there can be increased CSF in the cord, which may actually cause pressure within the cord as well. What are some of the systemic causes though? And this is where you really have to kind of put all these pieces, and our teams have to put all these pieces of the puzzle together and think sort of at the highest level, that 10,000 foot view, and then all the way down at the micro level at, you know, each individual injury view. Patients who have hemorrhagic shock, you know, that gunshot wound to the neck or to the chest, we're all focusing on the fact that that guy might be bleeding or dying from an injury to his lung. But the blood loss and the associated hypotension that occurs with blood loss actually will cause more damage to the cord and cause that injury to be increased or exacerbated. Any type of hypotension that the patient experiences, regardless of what the underlying cause is, can result in further damage because there's lack of perfusion to the neuronal tissue. Dr. Rossi again talked about hypocarbia, hypercarbia, hypoxia, and hyperoxia. Same principles here. Low carbon dioxide causes vasoconstriction. Hypoxia results in further ischemia to the cord. And then finally, hypoglycemia and hyperglycemia. So when you're thinking about your patients, it's very, very similar to a patient with traumatic brain injury. And so thinking about making sure that your patient, first of all, where is he bleeding from? So always in trauma, we think about where is the blood loss from, and you never think that it's only a spinal cord injury when they're hypotensive initially. There could be other reasons, internal bleeding, even if you can't see it. Always making sure that you try to maintain what we call end organ perfusion through that mean arterial pressure and making sure that they're well oxygenated. So reducing the risk for hypoxia. Whoops, did I jump? Sorry about that. Okay, so here's his vital signs. His blood pressure is 82/50. His heart rate is 54. His respiratory rate is 20 with some diaphragmatic breathing. His stats are 97%. That's pretty good. His end-tidal CO2 is 42. His GCS looks okay because he can't move. His glucose looks okay. He's warm and pink. His temperature is 95. I'm not completely happy with that, but I'm not like I'm concerned, but I can work on it. I prevent further harm is what I say on that one versus acting right away. He's got good breath sounds initially, and so let's ask a couple of questions. What are you thinking about with this diaphragmatic breathing? What's that tell you? Somebody's muted. People are muted. Sorry if you're talking.
Would it be indicative of a cervical spine injury?
Again, I'm sorry.
Would diaphragmatic breathing be indicative of a cervical spine injury?
Yeah, diaphragmatic breathing is likely indicative of a cervical spine injury or a higher spinal cord injury because their intercostal muscles can't be used. So if you think about it, you know, you've got your diaphragm down here, and most of you have probably heard in some other class that you've taken, C3, 4, and 5 keeps the diaphragm alive. And that's a really good little mnemonic or thing to remember. So if a patient has a cervical spine injury pretty high, their diaphragm just isn't going to work as well. But if you think about it, a patient who has an injury, let's say it's C8 C7, C8 level, or T1 or T2, their diaphragm may be okay, but what they don't have is that they don't have the ability to use their accessory muscles, their intercostal muscles, and even their abdominal muscles. And our intercostal muscles are what elevate our chest wall and give us tidal volume, give a patient tidal volume. So a patient who only has their diaphragm, their tidal volumes might be like 200 instead of the 400. They can't take deep breaths. So they're working really hard to try to generate that breath to get adequate ventilation. Even though they may be able to spontaneously breathe, they just can't get enough ventilation or tidal volumes, right? Anything else about their vital signs?
They're a little bradycardic.
Okay, he's bradycardic.
Got a low blood pressure.
He's got a low blood pressure. He's got a low systolic blood pressure. Which means and I look at that, he's going to have a low mean arterial pressure. Again, Dr. Rossi talked about keeping your mean arterial pressure a little bit high or above 65. So I'm concerned about that. Most of you work in places where you probably have monitors that give you a mean arterial pressure. Hopefully you can get a mean arterial pressure. Anything else?
His temperature is also a little bit low.
Yeah. We got to get him out of the clothes that he's got on, and we've got to start getting him warmed up because you don't want him to get colder. One of the hospitals I used to work at, we had a big sign in our trauma room, and it was 95 equals 35, just like it says right there. Now, that's not an exact correlation, but that was the big sign that we needed to ensure that we kept patients warm, because your platelets stop working when your body temperature gets below 95. And if your platelets don't work, you're not going to form a clot. That's the first line of your clotting cascade. So on the rest of his secondary survey, again, we already know that he's got abrasion to the top of his head. There's no bleeding or a little bit of bleeding. He's got pain with palpation to C5 and C6, but there's no evidence of deformity. He's got this diaphragmatic breathing that we already talked about. He's got no other signs of external trauma, but he does have priapism, which is a big red flag. When you see priapism in a male patient, that is truly evidence of a spinal cord injury. There's very few other conditions that priapism is going to occur except spinal cord injury. So that should be another sort of red flag or direct correlation to the fact that this guy needs to be fully immobilized and transported to a level 1 trauma center. And again, he says that he can't feel or move when you talk to him. So here's a couple questions. What are the pathologic processes? So he's got this injury at the level of C5. What are the immediate, or we think he has an injury at the level of C5 because that's where he has pain. So what immediate interventions need to be performed? What do you think?
Well, I would say that you need to immediately take precautions for the cervical spine, if not fully immobilize him.
Okay, absolutely. Put him in spine precautions and probably fully immobilize him. Anything else?
Start warming him.
Start warming him up. Get some warm blankets. What else? Or get some blankets. What else?
I did supplemental O2. Don't have to be a lot, but just to pump a little extra O2 if he's belly breathing.
Okay, I agree. Some supplemental O2. Many of you have the capabilities now, probably most of you have the capabilities for end-tidal CO2 monitoring. So I think that this is important, is to monitor not just their saturations, but also be monitoring their ventilation. And with end-tidal CO2, so do they have a rising and CO2 because now they're hypoventilating? Okay. What else? Anything else?
Work on that blood pressure some.
work on the blood pressure. So get an IV started potentially, and maybe give him a little bit of volume to see if we can't improve his perfusion, his mean arterial pressure, to ensure adequate oxygen delivery to his cord and to all of his vital organs. So this chart that you see on the screen is what we call the American Spinal Injury Association, ASIA dermatome chart. And you all can go to the ASIA website, American Spinal Injury Association website. They actually have, or they used to have, an outstanding CEU webinar that you could participate in, or not, kind of online thing, and get CEUs. I don't know if you can get pre-hospital, but it has a really good education program that's free. But this dermatome chart was actually developed years and years ago by the Spinal Injury Association neurosurgeons. And what you see right here is you see the orange lines on these levels. And each one of these levels describe where the nerve roots come out of the spinal cord, and then down the arms, down the back of the arms, down the legs, down the back of the legs, etc. And obviously down the arms to your hands at each level. So we typically think about, with sensation, the typical levels are C4 and 5 is your clavicle. If they can't feel you at your clavicle with your touching or rubbing their clavicles, then it's around C4 to C5. If they have no sensation below their nipple line, that's typically what we call a T4, around a T4 level of injury. We typically think about the umbilicus around T10, and then the pelvis, the top of the pelvis just below the waist, the level of T12. And then from a muscle standpoint, again, we say C3, 4, and 5 keeps the diaphragm alive. And then C6 is a patient who can flex their arms. C7 is a person who can kind of flip their hands up. C6 is flex, and C7 is extend, okay? I said that backwards. So C6 is a person that can flex their arms up. C7, they can put their arms down. And a person who can fan out their fingers can actually then is around T8, C8, T1 at the dermatome levels. So when you're thinking about a patient, can they feel their clavicles? Can they shrug their shoulders? Or can they feel below the nipples or at the nipple line? Do they have any ability to flex or extend their arms? And then obviously as you go down, if you're quickly assessing the patient, kind of gives you the level of injury for that patient. So he says he has pain in his neck. Again, the sign, pain in his neck. He has, again, pain. The other thing to think about in a patient who has, or the risk of spinal cord injury, I should say, is a person who starts to move and then they say it hurts in the back of their neck, right? Right here is your muscles, okay? This is not bone. This is muscle strain. Palpation down the vertebral column or pain in the vertebral column is the pain that we're talking about. And certainly, so if a person is trying to move or rotate their head or starts to move and they have pain, it's the back of the neck pain. And certainly as you're palpating down their spine, and obviously feeling or palpating any sort of deformity. And the way that people describe step-offs, if you think about the vertebral column, if you run your fingers down the back of the spine, you're actually palpating the posterior, or you're palpating the spinous process. So what you're feeling as you run your hand down the back of the spine is the spinous process. And a step-off is literally where two of those bones have moved apart and one spinous process is sort of further out than the others, all right? Or it moves out. So you'll feel this like notch, this big notch in the vertebral column as a patient, as you palpate down the vertebral column. What are other signs and symptoms? Guarding or splinting of the muscles of the neck. So now they don't want to move. Maybe they have pain all the way around, maybe even palpation, but a person who is completely, a person who's completely alert and oriented, has no distracting injuries, they don't have any drugs or alcohol on board, etc. They're not going to want to move if they have a significant injury. It hurts. They're trying to protect themselves. So that's part of a kind of a red flag too. And certainly, signs of any numbness or tingling in their arms or their legs should be that red flag for a patient who should be fully immobilized. And then signs and symptoms of neurogenic shock. I'm going to talk about neurogenic shock in a minute, so I'm going to defer to that. I'm going to defer to a later slide. And I already mentioned spinal or priapism with spinal cord injury. So the primary focus, again, is to recognize, for you all in the field, is as you're responding to a cause, to think about what do I have to think about? I've got a patient who has no movement in their legs or no movement in their arms, or maybe they aren't moving at all, but they're also unconscious. What is the risk there? So always err on the side of caution versus err on the side of C-spine clearance. And certainly your high energy mechanisms in the young population and even low energy mechanisms in your elderly population need to be considered. And then finally, with that full assessment and a really good hands-on assessment of that patient should be an indication for spinal restriction. So again, high energy blunt trauma, obviously lower energy in your elderly. I jumped ahead. Again, you're going to be out in the, there's tons of people at the James River right now that are rafting, they're kayaking, they're jumping into the water, their swimming pools are out there, etc. So just err on the side of caution with those. So it says, here's a question. Jade, tell me when I'm like 10 minutes out, or Greg or somebody. This is the patient reliable to evaluate his condition? So here's another question.
Our patient, I would say no.
Yeah, I would agree. Probably not. He had a loss of consciousness. You find as you get to the scene, you start looking at it. Maybe they were drinking. There's maybe alcohol on board, etc. And even though he's alert now, you don't know what degree of traumatic brain injury the patient may have had, or how long he was underwater. Any other conditions that would make you think that this patient is either reliable or unreliable?
Didn't in the beginning we said something about his GCS was 10?
Yeah. So his verbal score was 4 to 5. His motor score was 1. That's kind of what made it lower. But if he's not 100%, I would be concerned about that. So we've already sort of started talking about the fact that this guy probably needs to have full precautions instituted. Now, I'm sitting here looking at the instructor notes as I'm talking to you all and looking at the slides as well, and it says, consider removing the backboard, the scoop, or vacuum splint if transport time is anticipated to exceed 30 minutes. So that's PHTLS that says that. I think you have to defer to what your institutional and regional protocols are for that. The rationale behind that is, and the reason that we take patients off the backboards quickly when patients get to the hospital is that we look at the backboard as being a true pre-hospital transport device, and also the fact that patients who are lying on that hard board for a long period of time have no ability to have any sort of pressure relief, and the risk of the development of decubitus or pressure ulcers with that. And even the little bit of movement that a patient has as they're moving around in the back of an ambulance, you're transporting the patient, even tiny bits of shearing injury against the skin can actually potentiate the risk for that patient. So I think you really have to kind of ask the question with your providers, your hospital providers, and with your operational medical directors and the situation that you're in, about whether a backboard should be removed and that patient is placed on just the stretcher and then immobilized so that they can't move or sit up or anything like that, depending on the situation. And obviously, if the patient is unconscious, you're gonna make sure that you manage that patient as any unconscious patient is, or would be based on your protocols. So what condition, so the next question is, what condition could be causing this patient's vital signs to be abnormal?
His cervical spine injury.
Yeah,
Brainstem
his
injury.
spinal cord injury. And it's really neurogenic shock. And we'll talk about that in just a couple minutes. So getting the patient immobilized, starting an IV, administering IV fluids to maintain a systolic blood pressure of greater than 90 is important. And the reason that patients who have spinal cord injuries have lower heart rates is because there's this unopposed parasympathetic innervation. The sympathetic innervation is what is knocked out. So here's the slide that I've been anxiously awaiting that talks about spinal shock and neurogenic shock. So I describe spinal shock as the neurologic manifestations of a spinal cord injury. So a patient who has a spinal cord injury, especially a high spinal cord injury, it's usually above T6, okay? Above T6, okay, because the sympathetic plexus is around that level at T6. So spinal cord injury, they have no reflexes, they're completely flaccid, all right? And they have no sensation, all right? That's because there's this, this stunning of all of the neurons, okay? Just like the brain, they lose consciousness for a few minutes. Well, the spinal cord loses consciousness. It loses neurologic function. So flaccid paralysis and no reflexes. Neurogenic shock is the hemodynamic manifestations of a spinal cord injury. And again, only in patients who have a spinal cord injury above around T6. So if a patient comes in and they're flailing their arms, or you come up to a patient, they're flailing their arms, and all they can not move is their legs, and they have sensation all the way down to, say, their hips or down below their umbilicus, and they're hypotensive, the hypotension is from something else. It's not likely to be from neurogenic shock because they're moving. They've got innervation of that sympathetic ganglia that's in the spinal cord at around T6. So higher than that, then neurogenic shock is a problem. They lose vascular tone. That's why they vasodilate. So they're below the injury. They're going to be pink and warm, all right, because of this vasodilation. So and you've had, I think you've had your shock lecture already today or presentation. So the volume is there. It's not in the right place. We need something to refill the tank and then tighten up the tone. And that's the indication that we start thinking about using some sort of vasopressor like neosynephrine or norepinephrine to help tighten up the vascular tone and improve that unopposed parasympathetic innervation. So with all patients, regardless, you always want to think about airway protection. And if there's any other indications for airway protection or intubation, then you have to think about what that is. And certainly if a patient can't, has facial trauma, et cetera. A patient who can't ventilate may need intubation to support ventilation. Support their oxygenation with some sort of supplemental oxygenation. And then again, maintain their systolic blood pressure above 90 so that you can keep their mean arterial pressure above 65 to ensure that you have adequate perfusion to the spinal cord. And then we talked about why we want to keep this patient warm or normothermic and early transport to a trauma center that has the specialty resources to provide care to patients with spinal cord injuries. So let's reassess this guy's vital signs, and we're just about finished. His blood pressure now is 92/54. His heart rate is still 54. It feels a little bit thready. He's still breathing about 20 breaths per minute. His SATs are still okay. His end-tidal CO2 looks decent, and his GCS is still pretty good. His verbal score is 5, so I'm pretty happy with that. And he's still able to complain of pain. You've made the decision to package him with full spine immobilization, and you've got your IV fluids running, and you've given him a little bit of a fluid bolus, 250. Don't give him 3 liters. Give him 250 or 500, see what happens. Give him a little bit more and see what happens as you take care of this patient. Should we give this guy any pain medicines?
With that blood pressure, I probably wouldn't.
Okay, I would agree that you have to think about what medications you have in your scope of care that would not further potentiate this patient's hypotension. And if you say again,
would you be able to use fentanyl?
Yeah, you could probably give him a little bit of fentanyl. I would give him a whiff. I wouldn't give him, like tons, but give him a little bit. You don't want to not maintain or give him some pain medicine, but you certainly want to make sure that you don't drop his blood pressure anymore. Now my slide deck and my speaker note says, could atropine be given for the patient's bradycardia?
Probably not.
Probably not. And I would actually agree with that initially. My guidance to you, PHTLS says you might be able to give it in intermittent doses. If there's really significant hypotension and bradycardia, this is one where if I were in the field, I probably would call medical control and ask that question before I gave it. But I would certainly try to give him volume first and see if that doesn't help his perfusion and then his heart rate. Here's another question. It says, should steroids be used as treatment for spinal cord injuries? And I'm looking on the screen of the people that have pictures or are live, and I don't see too many people that have been around long enough to remember when we gave steroids to patients with spinal cord injuries. That was pretty much the standard of care back in the 1980s and 1990s and even into the early 2000s. And there were some studies that were done back in the early and mid 1980s that demonstrated that if a patient if you gave a patient a steroid load of 30 grams per kilogram and then ran this infusion over 24 hours, that there was some improvement in that patient's overall neurologic recovery. They didn't get up and walk out of the hospital, but they might gain a level or two in their recovery. But there's also a lot of complications associated with the steroid administration or high dose steroids. So probably since the mid 1990s, when there were some publications that came out that said you should not give steroids, we sort of stopped giving that. So it was it really took about almost 10 years for people to really start embracing that recommendation to stop giving steroids. But we don't see it given except in a really, really rare circumstance now. I always tell the ED nurses, if you have a doctor that says, give this patient high dose steroids, you tell them that they don't keep that much Solumedrol in the pharmacy, so they can't give it. They're going to have to go to another hospital to get that, just because it shouldn't be, it's not recommended. So here's your case summary. You transport this guy to a level 1 trauma center. He has what is called an incomplete injury, meaning that part of the cord at the level of his lesion is preserved, the function, or that there is no damage to the cord itself. So there's going to be some degree of function that's preserved. And he was actually able to be discharged to a rehabilitation facility and ultimately discharged home. Great job to everybody and the decision making. So here's just some summary slides. Disability assessment. This is crucial in your overall assessment in patients with these really significant energy mechanisms. And you all, again, we rely on your really good judgment. We really do rely on your critical thinking and assessment at the scene and the decision making. So, you know, use that in what's best and always sort of err on the side of caution if you have a concern. Certainly the reassessment of your interventions is important. And then we've talked a lot about when the indications are. And again, I will always defer to what your individual agency protocols are, but to try to minimize any sort of secondary injury is really important. And then we talked about the difference between spinal shock and neurogenic shock. Any questions? Okay, well, if there's no questions, thanks a lot, everybody. I hope you have a productive rest of your day.